general types of voluntary euthanasia. In active voluntary euthanasia, the physician takes premeditated steps to curtail the patient in accordance with the wishes of the patient. People are often familiar with the term physician-assisted suicide. The alternative is passive voluntary euthanasia, which also respects the wishes of the patient. The physician lets the patient pass away by refraining from intervening in the patient's treatment. There are several camps in favor or opposed to the legalization of voluntary euthanasia. According to a survey by the Pew Research Center in 2005, 84% of all surveyed persons approved of laws that let patients decide whether or not they are kept alive through medical treatment. Since 1983, Harris Interactive has reported a 17% increase in support for a law allowing doctors to comply with the wishes of a patient who asks to have his life ended.
Medical advancements in the 1960s raised the question of how long and under what circumstances life should be sustained by medical means. Later, in 1973, the American Hospital Association recognizes the right of patients to refuse treatment. By the end of 1976, California approved the nation's first law giving terminally ill the right to authorize withdrawal of life-sustaining medical treatment when death is imminent. 8 other states passed similar laws within the year. Perhaps the most famous in the movement in favor of euthanasia is the pathologist Jack Kevorkian. He helped nearly 140 people end their lives. Jack Kevorkian was sentenced on April 14, 1999 to 10 to 25 years in prison. Today, voluntary euthanasia, also known as physician-assisted suicide, is legal in 4 U.S. states: Oregon, Washington, Montana, and Vermont.
Several arguments for and against voluntary euthanasia have developed over the years. Those against voluntary euthanasia have argued that suicide is unacceptable even for the ill. Some people also believe that it is incompatible with the healing goals of medicine, if not unnecessary with proper medical care. There could be unexpected tolls for people other than the patient as well. Requests for death may be simply induced by poor medical care or for unrecognized psychological needs. The practice may also be damaging to physicians by desensitizing them to human needs. Additionally, many people fear that legislation legalizing voluntary euthanasia would be a slippery slope to indiscriminate killing of the ill, weak, and disabled. Conversely, the rationale for supporting the legalization of voluntary euthanasia focuses on protecting individuals who no longer want to suffer lingering, painful deaths. Voluntary assisted suicide respects patient autonomy. It does so by protecting against physician paternalism and unwanted treatment that may not assuage their suffering, but instead turn it into a futile and costly measure. By not legalizing voluntary euthanasia, we are infringing on people's rights. The state should not have an interest in stretching out the life of a person who wishes to die. Moreover, some debilitating medical conditions are not easily managed by medicine.
The current views on voluntary euthanasia are compelling. We thought that it might be best to talk to an expert on the situation to better understand the conflict and the shift in society. Dr. Shea, Associate Dean for Undergraduate Studies and Outreach of the College of Health and Human Development, provided an insight from the health policy perspective. Currently, if someone commits suicide, health insurance does not compensate the family. This situation may change if physician-assisted suicide were legalized. According to Dr. Shea, you would need to have a conversation with the life insurance industry because people can obviously take advantage of it. This is what we call a moral hazard. If people are going to be allowed to do that, we have to have some changes in policy first. From a company's point of view, they could be at risk of not collecting enough premiums, which would be a financial problem. With that said, there can also be a financial burden on families to ensure palliative and end-of-life care. During the interview, we also questioned how the legalization of euthanasia would affect funding to medicine. While Dr. Shea indicated that we would not necessarily see a large general impact, new challenges would arise. Organizations that feel strongly on the issues, such as the National Association of Pro-Life Nurses, National Hospice and Palliative Care Organization, and other various religious groups, would apply pressure to government agencies that provide funding. He raised the question, would Medicare or Medicaid cover that service? For example, Medicaid is not allowed to fund abortion services. A lot of these types of organizations are funded by private donations and tax dollars, so they would receive a lot of pressure from private interest groups that do not support the assisted suicide. For example, Planned Parenthood faces a lot of this kind of pressure. There is another ethical question regarding whether poor quality end-of-life care should be taken into account when considering physician-assisted suicide. Dr. Shea expressed, I think that there can be a lot of pain at it in these times, and involvement of family members is nice. It's good to have good respite care. If there were better care, people might so often choose to end their lives. There is evidence that we might be too aggressive with our care. Many people would rather die in their own homes, but they end up dying in the hospital. There are some studies that show they will live longer if we treat them with more care rather than so aggressively. This could result in people not often wanting to end their lives. To legalize voluntary euthanasia, a complex protocol would need to be established. When asked about how it would affect the physician and what the measures would have, Dr. Shea said, I think that physicians would want to have multiple safeguards built around this process. I would expect there to be a waiting period between the expression of that wish and the final decision. They would want some sort of consultation with the family and maybe even another physician. They don't want a family member to take action against the physician. What kind of decision is that? One of the issues is definitely whether or not the patient is competent enough to make that decision. I would think that the fundamental principle would be that it is the patient's decision, but the decision has to be made with full understanding and with opportunity for a family member to be involved with the process so that those sorts of principles are met.